We're going to move on to the thyroid. This is probably the difficult part right after lunch. You're going to get hypoglycemic. So if you hear, don't look down, look up, I'm talking to you. So actually, I went to church once and I fell asleep and this pastor kept saying, don't look down, don't look down. And my wife's like, come on, wake up. So anyway, yeah, so the thyroid, I'm going to be talking about hypothyroid, not overactive thyroid, but hypothyroid. And, the thyroid gland is a beautiful, it looks like a butterfly. It sits right there in front of your neck. And, when I go to the store, actually what I look at is your thyroid gland. I think it's sexy if it's really big, but I would really salivate if I see something like that, a huge goiter, because I rarely see that these days. In my earlier practice, I would see some from West Virginia. They would come up and get evaluated at University of Pitt, and we saw, actually, I did a year of critical care medicine at University of Pitt. When I did my 3 years in internal medicine in Allentown, Pennsylvania, I fell in love with two different subspecialties on opposite spectrums of the world. One's critical care and the other one is endocrinology. And I had two great mentors, and I liked both, so I decided I'm going to do 2 fellowships and, I guess, pursuit of knowledge. But we saw a case at University of Pitt, a truly mixed edema case, where this woman who had like 5 kids barefooted from West Virginia really had hypothyroidism. Her TSH was like close to 1,000. She was bradycardic. Her core temperature was like 32. She was very sick, low blood pressure, required tons of medicine. And so some of my best cases that I still remember is from West Virginia. So but I was there this winter for spring break. We went to Snowshoe Mountain, and it's a beautiful place. It's just a lot of stories about West Virginia. All right, so you can see one actually has a goiter, another one actually, if you can't, it has a little scar, the thyroid removed. Hypothyroidism, there's approximately 25 million Americans that have underactive thyroid, and there's about 12 million that are undiagnosed. Actually, a little statistics, there's more people with underactive thyroid than diabetics. So it's much more prevalent. So I'm going to cover about 4 different subjects. And actually at lunch, I was talking to one of the attendees here, and we were talking about iodine plus causing his thyroid to basically fail. But I'm going to be talking about the dangers of excessive iodine and show you the data. And there's another doctor on the internet just praises iodine, but you got to be careful about it. And then the dangers of ignoring TSH and just using free T3. And I've been to many conferences where it's just like, forget TSH. It's a useless hormone. Look at free T3. And I'll show you the data, and hope at the end you'll probably understand why you should not ignore TSH. And then understand free T3, reverse T3, but more reverse T3. And that's really important. And the benefits of using T3, T4 therapy. So back to the typical classic feedback loop. You have remember the hypothalamic area secretes a hormone called TRH. It goes to the pituitary gland that secretes TSH, and the thyroid secretes majority of the thyroid hormone T4, about 90% and 10% T3. And then there's a negative feedback loop that goes back. And if it senses that the thyroid is failing, then basically TRH and TSH will both go up to try to whip the thyroid to make more. So remember, what we eat is what we put in our body helps our body to work better. And the thing is that actually it looks much better if I look at this way than that tiny screen there. But the thing is that in our diet, if we have seafood or iodinated salt or even some vegetables, we're going to have iodine. And then the other part is tyrosine. So you combine iodine and tyrosine, and you're going to make the thyroid hormones. So if you're deficient in one of them, or you have problems in absorbing or breaking down your proteins to get your amino acids, then you're not going to basically make your thyroid hormone. So digestive enzymes are important too. So you can see that iodine goes to iodide, and then with tyrosine and oxygen, you make, we're going to go more into detail, called the MIT and DIT, which is the precursor of making T4 and T3. So through our diet, that's how we make our thyroid hormone. So this, I'm sure you all remember that. So the biosynthesis of T4, T3, this is kind of what I mentioned about, but the thing is that we need iodine. So when we ingest iodine, the recommended minimum intake is 150 micrograms, although there are people that recommend like 25 milligrams. Active transport of uptake of iodide by the thyroid gland, and then it gets oxidized, and then you get the iodination of the thyroid globulin on the tyrosine molecule residue. That process requires thyroid peroxidase, and then you have the coupling effect of MIT and DIT, and then basically you have the release of the thyroid hormone from the thyroid cells. So here's a picture of MIT and DIT. One's called monoiodotyrosine, and the other one is DIT, which is basically deiodotyrosine. So basically, DIT has 2 iodine molecules, and MIT has 1 on the tyrosine molecule. So when you combine like MIT to DIT, you can make T3, and if you combine 2 of the DITs, you have 4 or T4. So again, you know, what we ingest, if we have iodine in our body, it gets absorbed as iodide through the sodium iodide transporter, and it's called a symporter. And then eventually it gets into our cells, and then the iodide gets oxidized, and then there's the iodination of the tyrosine molecule of the thyroid globulin. And that iodination process right here, right there, this is crucial for you to understand, it requires an enzyme called thyroid peroxidase. So if you have, so just remember, thyroid peroxidase requires that iodination, that process right there. And then you're going to have basically eventually release of T4 and T3. So the thing is that if you have positive thyroid antibodies, this is a really important point. So if you don't understand it, I'll try to explain it a different way. But if you have Hashimoto's and you have thyroid peroxidase antibody, what you have is an antibody that's attacking the thyroid peroxidase. And remember, thyroid peroxidase works right here. So if you give someone high doses of iodine with someone with positive thyroid peroxidase antibody, that extra iodine wants to basically go onto here, to make more thyroid hormone, and you have a positive antibody that's basically going to destroy that thyroid peroxidase. You're activating thyroid peroxidase with extra iodine, and then a positive thyroid peroxidase antibody, you're actually destroying that antibody. So you're actually destroying that enzyme, the thyroid peroxidase. So the thing is that you're going to destroy your thyroid faster if you have basically Hashimoto's with positive thyroid peroxidase antibody. So if you have positive thyroid peroxidase antibody, do not give extra iodine. I hate the thing when people go to the health food store, oh, you have a thyroid issue, here's like Lugol's solution, take extra iodine. Down the road, the thyroid is going to fail, guaranteed. So this is really just the understanding of basically the mechanism of why you should not use extra iodine, especially with autoimmune thyroid disease. If you don't know they have autoimmune thyroid disease, then have them do a blood level check and see if they have it. So this is a slide that basically, you know, you have T4. Majority of T4 gets converted to, it can go into T3 or reverse T3. And reverse T3, usually it's made in, both converted through the liver. And then both of them can get break down to T2. And they require special enzymes for getting into T3. And there's different special enzymes to convert that. So you have these deiodinases, and the most important is D2. I mean, you can look at D1, D2, D3, but D2 is the one that basically some people have. You can look at their genetic SNP, and they cannot convert T4 to T3. And that's why there are some patients who feel better with a combo thyroid pill like T3, T4 versus T4 by itself, because they cannot convert their T4 to T3. So they're going to reverse T3 and they feel terrible. So I'll show you a study that shows about approximately 16% of the population in that study were deficient. They were actually not a deficient, but a genetic defect in converting T4 to T3. Yes, Jamie?
Why aren't they recommending the combination formula? Because typically they come in and they're on maybe just a T4.
Well, I was going to have a funny remark with that, but anyway. Not everyone understands the thyroid really well. So, you know, most endocrinologists, I was down that road and I just gave T4 like crazy. And that was my, brainwashing years where I went to medical school and used Synthroid and was a big believer. And then, eventually down the road, I learned a lot, read a lot. And so now, you need T3. That's the thing. And there's, sometimes you have to compound it, a different percent. When you use Armor or WP Thyroid and Nature Thyroid, it's generally 4-to-1, 4 molecules of T4 to 1 molecule of T3. But some people need, like, backwards, 4 molecules of T4 and 1 molecule of T4. Everyone's different, that's the thing. So why does everyone, that's the good news is that it puts me in business, so.
We also have patients come in that, we've got patients come in that have the thyroid removed when they need a Cytomel or a T3 or something like that.
Yeah, when they have their thyroid removed, you can add a Cytomel with your T4 or use a mixed T4, T3 combination. There's many different combos. We'll talk about the therapy and all the different permutations. And so there's all these different ways. But remember, D2 is a deiodinase, and that's the important part, convert T4 to T3. So T4 is a pro-hormone for T3 if it gets converted there. Otherwise, it goes to reverse T3. And there's basically a difference between, you can see T3 and reverse T3. You can see the iodine with those green little dots there. So one's on the outer ring that's missing for T3, and reverse T3 is missing the iodine in the inner circle. So that where the iodine's located, it determines if you have T3 or reverse T3. So what I tell my patients is that imagine your thyroid's like a seesaw. And if you have too much reverse T3 and not enough T3, and you can do a blood test to see how much reverse T3 you have and how much T3 you have. If you have tons of reverse T3 and low free T3, generally you're going to be, you don't have to have all three, but you'll be tired, you'll be fat, and you'll be cold. But if you're postmenopausal and you're complaining of hot sweats, you may be hot. But anyway, generally you're going to be cold, tired, and you have problems with your weight. So what I do is try to detox, get that reverse T3 down, or use T3 to basically change that ratio so you optimize your free T3 and lower your reverse T3. And that's what I do all day in my practice. I mean, it's one of those things that we try to tweak it, and there's levels that, I'm trying to shoot for reverse T3. I mean, each lab is a little different, so they have different units. But anyway, the thing is that that's kind of the simplistic view that I tell my patients. It's really, if you're out of balance, my job is to balance you to get your free T3 up and reverse T3 down, right? Everyone got that? All right. So T4 gets majority converted in the liver, and if your liver is weak and you have so many environmental toxins, guess what? It's not going to go to free T3, it'll go a lot of reverse T3. So I have a lot of people who've seen a lot of doctors, they're tired, fatigued, and they get their TSH checked. And so in their TSH is like 1 or 1.5 and said, you're normal. But you check that reverse T3 and the free T3 is generally kind of very low normal, and that reverse T3, let's say optimal is less than 10, is like 20, 24, way too high. And you got to really work on detoxing. That's why I put that talk about detoxification. There is some small percentage of T4 gets converted to T3 in your kidneys. So when T3 goes into your cells, T3 basically binds to a nuclear receptor, turns on basically your DNA, and makes basically proteins. So it can help with metabolism, your cardiovascular. For cardiovascular, it increases your cardiac output, so it also increases your heart rate, increases oxygen delivery. For metabolism, increases ATP production, so if you want more energy, you gotta basically make ATP. If we make 0 ATP, what happens to us? What? Well, besides no energy, we're dead. So that's the definition of death. It's we make 0 ATP. So you're not quite sure if that guy's dead, check their ATP level. All right. It actually increases O2 consumption, it increases your metabolic rate. So that's the key, is really if you want better metabolism, you want your patients to lose weight, you want them to have more energy, you got to really work on that, optimizing that ratio. So reverse T3, think of it this way, it blocks T3 to get into the cells. So if you have too much reverse T3, it basically hangs around and blocks that T3 cannot get in. So that's the whole thing. You want to reverse that reverse T3. So everyone understand that concept? It's pretty simple. All right. Because this concept that you just learned, you know more than most endocrinologists out there that's board certified. So although when I was studying, we did talk about reverse T3, but we really didn't, I never got taught on how to lower it. So that's the whole thing. So it's in the literature, it's just that, but you're way ahead of most board certified endocrinologists. So the next slide is, this is a puppy before and after. Could be the diet, or could be thyroid, could be cortisol, could be some other hormones too. But I just say it's hypothyroid. Dogs and cats have thyroid issues. That's interesting. So I hear a lot through my patients that, yeah, my dog takes thyroid medicine, and so I'm just curious what their range of normal is, because I never get to see their labs. All right, so generally, if you have an overweight dog, the owner is usually overweight too. So. And we just got a puppy. It's about a year old now, and this vet was saying, okay, your dog weighs less than 10 pounds. I want to gain 3 more pounds. I'm saying that's 30% increase. He's going to get diabetes. He's going to have high tension. It's like, what are you doing? It's like, that doesn't make sense. Why would you want to make this? This is a small dog. It's a Maltese Shih Tzu. It's not a big dog. 3 pounds, it's like, holy cow, he's gonna have metabolic syndrome and insulin resistance, and he's gonna have early plaque production. He's gonna die. It's like, why do you want to get 3 pounds? It's like, just do the surgery. Clean his teeth too. All right, so so T4 can get converted. Remember the D2 or the 5' deiodinase into T3. That's what you want. Reverse T3 basically is generated, but if you have too much reverse T3, then you're going to be cold, tired, and you have problems with your metabolism. But stress, fasting, illness, cortisol, all basically pushes the route where you go more into reverse T3 pathway. So I gave a lecture once in Orlando to my patients, and I was talking about the thyroid and how sometimes it's environmental toxins that can cause your thyroid to basically fail. And if you look at the periodic table here, iodine is on next to that red line there. It's right here. And basically, on that line there, you have fluoride, chloride, bromide, iodine, and antimonium. And they're basically very similar to each other. And they can connect into the tyrosine molecule, so you have an inactive thyroid hormone. It displaces iodine. So I had a woman that basically told me later, she goes, I switched my pools. Well, she changed it from chlorine to basically salt water. In Florida, everyone has basically a pool. So anyway, salt water is kind of like the latest thing that you can get. Just it's easier. You don't have chlorine and all that. And down the road, I will convert my pool into salt water, but I just haven't had the time. But the thing is that her thyroid test improved. She felt better. So she swam a lot. I mean, I'm a swimmer. I swim about 1 or 2 times a week with the masters. But the thing is that if I swim in the open water in the lakes, I always get sick, especially in the summer. I swallow too much of the lake water. But the thing is, I have too much parasites that come in that way. But the thing is that, anyway, you got to ask your patients, do you get exposed to chlorine? Do you swim a lot? Fluoride, fluoride toothpaste. It's loaded. Almost every toothpaste out there that's conventional basically, has fluoride in there. Bromine is interesting. It's in breads and Mountain Dew, flame retardants. I like to eat flame retardants, but lead and mercury. That's the top 2 things I see in my office is when we do heavy metal testing, it's lead and mercury. That can inhibit T4 to T3. Stress, pesticides, aging, diabetes, surgery, cigarette smoking. And then you could see the rest of the things here. So I was talking to another doctor who says he sees a lot of problems with T4, T3 conversion, right? So, all right. Other things that can inhibit T4 to T3 is, if you use a lot of iodine is kind of funny. Iodine is that molecule you don't know if it'll go this way or that way. And some people respond beautifully with iodine, and if they have negative thyroid process antibody, I give them my blessing. I say start slow and see what happens. But I have people that take iodine with negative thyroid process antibody, and their thyroid goes from normal to, slightly sluggish to worse. Their TSH climbs. And it's kind of an interesting phenomenon. I mean, some people respond well, some people don't. But, if you're deficient in iron, you're not going to convert T4 to T3. Deficient in selenium, deficient in chromium, deficient in zinc, and all these vitamin A and B6 and B12, the B vitamins, you're not going to convert T4 to T3. That's why it's important if you want to do some advanced studying to look at their nutritional status and see exactly what nutrients that they're low in. Because if you want to really have optimal health, you really need to have optimal nutrition. So the benefits of T3, T4, yes?
If somebody has Hashimoto's and elevated antibodies and you get them down to a normal range, would you then consider iodine or no?
So I'm going to repeat the question. So if someone has Hashimoto's elevated thyroid process antibody and you get their TPO antibody down, would you use, depends what level. I mean, if it's less than 20, yes, it's considered normal. But anyway, when you say normal, I don't know what your normal is, but if it's less than 20, yeah, you fix them. Whether it's, I've given an hour talk on how to reduce thyroid peroxidase antibodies. So, getting gluten out of the diet, fixing leaky gut. It's really sometimes using systemic enzymes to help lower. That helps help. A plant-based diet that has also helped some of my patients. So. Yeah, so there's different things you can do to help in terms of lowering thyroid peroxidase antibody. It's usually not all the time, but selenium has been shown to work, 200 micrograms of selenium a day to lower their TPO antibodies. So the other thing is that I always have to remember, is it CME or non-CME? So anyway, I use a systemic enzyme from Germany, WOB enzyme, professional strength. I've seen people dramatically improve. And their recommended dose is like 15 pills a day. So I tried it I've never tried 15 a day. That's a lot. So I tried 5, and I finished the bottle. But I've seen people just taking one a day and have dramatic improvement. So I think it's, for some people, 2 or 3, 4 pills a day, it really lowers it. I would rather them being compliant with their regimen than scaring them off. And I have an assistant, and he believes, it says 15, you've got to do 15. I was like, Jason, not everyone's like you. I want them to come back. So anyway, the benefits of T3 and T4 therapy. I remember there was an endocrinologist from Johns Hopkins, and there was an endocrine meeting, and there was this article that came out in New England Journal of Medicine with T3, T4 combination helping with depression and helping with energy and helping with all that. So we got in the news, and I remember this board, he's one of the leaders in the endocrine for thyroid expert. And he looked at all the data, and at the very end, at the conclusion, he goes to all the endocrinologists practicing and said, there's not sufficient data to support use of T3, T4. That was the thing. Even though that data clearly showed, the New England Journal of Medicine basically showed cognitive, mood, and basically it all significantly has all improved. And there are other data that basically is equivocal or same. So here's one study that I want you to get out of. It was a study that looked at T3, T4 versus T4. And they had 552 patients from the UK on T4 therapy. It was randomized placebo double-blind study. So this is the gold standard way to look at medical studies. The primary outcome is psychological and well-being. And it turned out 16% of the population in that group had a SNP for the D2 gene. The D2 gene converts T4 to T3. So they could not make T3. And they had greater improvement with the T4, T3 group. And basically, that's a small little population, 16%. I'm just guessing probably 20% of the population out there has a genetic SNP in terms of converting T4 to T3. That's why some of your patients are on 100% T4, whether it's levothyroxine or Synthroid or Tyrosint, they're going, I don't feel good. And you got to check their reverse T3 and free T3 and see where they're at. All right, I see a couple people, eyes are like getting heavy. So don't look down, look up. Look up. All right, so here's a study of 50 patients undergoing a thyroidectomy, and the group that got the T4, T3 supplementation or hormone replacement improved in everything. They felt better. So I look at, there's something called free T3, reverse T3 ratio. I used to do tons of this. And I just found that if you just try to get the reverse T3 down, it's just as good. There's a calculator. I'll show you the website. You do the calculator. But I find that a little more time consuming. And, it's one of those things that it was interesting at first. I used to do a lot of that. Now I just look at reverse T3 and say, these are the things we're going to do to lower that and get your T3 up. Not many studies out there in terms of free T3, reverse T3. There are very few studies. There's nothing really much published out there. But the thing is that in 14 neonates with respiratory problems, a higher free T3 and a lower reverse T3 predicted survival. A small little study. So reverse T3, free T3 ratio was significantly different between survivors and non-survivor. So they just basically looked at, the ratio and said that if you had more free T3 and less reverse T3, you did better. So there's a ratio you can look at. It should be over 20, but it's very confusing because there's so many labs out there, whether you use Quest or LabCorp or you use some other labs. They have different units for reverse T3 and free T3, and you can't just plug one number divided by other number. You have to convert, so the two ratios are. So my son actually, who's in 7th grade, just finished, he actually got invited for the Duke TIP program, so he was invited to take the SAT in 7th grade. And so they're just looking for young talent. So I majored in mathematics, so I'm kind of proud, like, hey, I can help you in math. But I think that was like, in retrospect, I think I should have never, even been involved with it. I think I traumatized our relationship. But the thing is that he had trouble converting a couple things, because you have to have the same units to take a ratio. You can't take picograms per deciliter divided by micrograms per milliliter. It's not, you have to have the same units to make a ratio. So there's a converter. If you go to this website, you just plug it in, you find the units, and it converts for you, and boom, you get a ratio. And if the ratio is over 20, then that's good. So I have some people, the ratio is really low, and then we get the ratio up, and they feel better. So how can you work on lowering reverse T3? So the talk before lunch was about detoxification. So it's really optimizing your liver. It's really about removing toxins, but the thing is you're trying to basically get the phase 2 working a little better if you had to just pick one part of the liver, phase 2. And you may need to supplement with NAC. So if you have, let's say, a Tylenol overdose, you know what they give in the emergency room? Because it's going to damage your liver? They give you NAC, N-acetylcysteine, or Mucimist. So that's going to basically help with removing your Tylenol overdose, because NAC gets converted into glutathione, and glutathione is a key ingredient. So glutathione is like the most important antioxidant. It's one of the key things in terms of methylation is for phase 2. So glutathione is really important. There are several, we use a lot of IV glutathione pushes in my office, but for those who cannot come to my office, there are several glutathione preparations that we've tried, and I've been able to show by their blood work it does work. But it's not like I have a lot of patients that I'm confirming, but not many companies out there actually can support that, because they have a glutathione, liposomal glutathione product. Actually, it's bioavailable and it actually works. But anyway, if they're on a combo therapy, you can consider lowering their T4 and bumping up their T3, because T4 can get converted to reverse T3. And you may, if they're just taking T4 and you have some room, you can add some T3 to it. So that's how you can improve on the ratios there. So that's kind of 1, 2, 3 what you can do. So you can start that on Monday. So this is kind of a hot topic for me because I've been to a lot of these conferences, age management, and where I've heard a lot of these speakers, very dynamic speakers, and to say, TSH is useless. And I was like, what are you talking about? TSH is useless. TSH is we need this. And the thing is that TSH has changed. The reference range has changed. It used to be that TSH before 2003 was 5, and then now after that it's dropped down to 2.5 or less. This is a kind of an old slide. So optimally, I like a TSH around 1. It's just easier for the patients to remember. 0.3 is acceptable, although some labs report like 0.4, but most endocrinologists consider 0.3 like to 2.5 normal. And if you're above 2.5, you're beginning to have underactive thyroid, called subclinical hypothyroidism, and you're at a higher risk for heart disease if you don't get your thyroid corrected, because there's many different reasons, but one reason is that the thyroid is really important to regulate your cholesterol. But cholesterol is not the big, cholesterol is part of the crime scene there. So TRH and TRH like peptides. So TRH, like peptides, I use a lot of starting to use a lot of peptides in my office. Really excited about peptide therapy. And I have not used the TRH like peptide. But anyway, it's out there. And the thing is that it shows that it's neuroprotective. It has antidepressant effects, anti-epileptic effects, and people can lose some weight with this. TRH is found not only in the hypothalamic area, it's also found in the GI tract. It's found in the other parts of the brain, placenta, testes, prostate, retina, pituitary. So it's throughout the body. And there's a TRH analog. It's been out for over 20 years. It's made in Japan. And they use it for treatment of spinocerebellar degeneration. And basically, it also helps relieve pain. It's off-label use. So it's kind of an interesting thing that TRH can do some unique things. There's a study they're using a TRH analog called NP647, and it basically they're showing that it's helping cerebral ischemia. So if you have a stroke, they're consider using this. It decreases inflammation, and the key in our whole talk, I mean, besides getting your hormones balanced and removing toxins, is really reducing inflammation. And you need some inflammation, but if too much inflammation, that's not good. So it reduces TNF, alpha, also IL-6 and lipid peroxidation. And it decreases excitotoxicity. And in addition, it'd be exciting if this is another treatment for cerebral ischemia. So when you suppress TSH, you're suppressing TRH. So if your TSH is 0.003, that's really suppressing it down to 0. So TRH regulates the hypothalamic pituitary thyroid axis. And the thing is that TRH also stimulates the mitochondria. TRH also stimulates the melanocyte-stimulating hormone. So what's interesting is that who would like to have nice, shiny hair and you don't gray? Well, maybe down the road you have the TRH analog and you can basically help your hair not be gray. So that's kind of a cool thing. So TRH interacts with the immune system during development. TRH can be either stimulatory or inhibitory. And TRH has been found to be neuroprotective. So these are like, 2009, 2011 data. It's not like 1986. This is like, kind of the current stuff that's out there. So there was a study on fatigueness, TRH on fatigueness. So 8 patients with cancer, all cancer patients generally fatigued. They underwent a randomized placebo-controlled crossover study with IV TRH. And it shows a significant improvement in the quality of life. So actually, you can see what it did, but the bottom line was it did help with energy. So TRH promotes wound healing. So for the wound centers, besides using hyperbaric oxygen and using zinc and IV nutrition and using growth hormone, you can actually consider using TRH to help with wound healing there too. So TRH may also help with neurodegenerative disorders. So I actually have a pastor, Pastor Dave, who just came to see me. His daughter was living in Korea. So I have patients who from all parts of the world. He actually doesn't live that far, but he has very aggressive ALS, bulbar ALS. So he can't speak. He's, has saliva coming down. So he's probably 6 months. So they're just tired of nothing to do. So his daughter found me on the internet, and they flew down. Well, she flew from Korea to be with him, to see what I can offer. And so we're offering some cool things, but I'm really giving phosphatidylcholine intravenously. We're also doing a lot of liver cleanses and detoxing and optimizing his testosterone and growth hormone, using peptide therapies to get the growth hormone. Because all ALS, they lose their respiratory muscle. They're so weak, they become more catabolic than anabolic. So he's falling apart. And just the first IV therapy, he already felt better. So the thing is, I don't think I can cure ALS or anything like that, but it's one disease that somehow I get some very difficult cases, and I'm thinking about using PRP therapy to get the growth factor. I mean, it's kind of poor man's stem cell therapy. So I'm just thinking outside the box what we can do. But right here is I may get a TRH peptide to help with this neurodegenerative disorder. Remember, it's environmental toxins, and to remove toxins, you got to detox, and that's the best way, I think, is intravenous. So, TRH on weight loss. So, the old days it was just, use your thyroid medicine, bump it up, and you'll lose some weight, but it doesn't work all the time. I think you really have to really reduce insulin resistance, which we'll be talking about on the next talk. But here's a study that shows that it actually decreased leptin and also helped, they lost some weight there. So it's small little studies. So the bottom line is that why would you suppress TSH if you know all this data? Why do you want the TSH down 0.0003 with using, ignored TSH? And if you understand the science, you would never do that. So I have few patients that have low TSH for years, and I'm trying to maybe slow them down or reduce it, but I check their bone density or do a urinary N-telepeptide to look for bone loss. And especially after 50, if they're over-replaced, they're going to start losing bone. So you can do a simple urinary N-telepeptide, and if they're over 30, then basically, guess what? You have to back down the thyroid medicine because it's too aggressive. Or else they're going to lose, they're going to get smaller and shorter. All right, the last part is iodine. So this is iodine is generally found from the ocean and seafood, and it's basically in bread and dairy products, and there's iodinated salts and dietary supplements as a trace element. So it's been fortified in flour, iodine. So in the United States, a long time ago, in the 20s, there were goiters everywhere. And then they decided, let's iodinate the flour and salt. And so now we have a decrease in goiter. So if you're from the Midwest and you're not exposed to seafood and all that, that's where you get more goiters. So there are countries around the world that still have goiters because they don't get enough iodine there. So it's misleading that you can use 50 milligrams iodine per day is absolutely safe. Previously, the Japanese consumed a daily income. They thought that the Japanese ate 13 to 15, so 45 milligrams of iodine a day. Then the Ministry of Health in Japan basically says it's really 3 milligrams of iodine a day. And there was a study by Dr. Zava's son, who actually with the ZRT lab, I actually met him. He actually went to Japan and did the study, and he said that it's really, they're only consuming 1 to 3 milligrams of iodine a day. It's not the previously thought that they were eating, up to 45 milligrams of iodine a day. So that data, once it's in, it's one of those things medicine, it's like, how did we learn it? Well, if you were a surgeon, how did you learn it? Well, your mentor taught you. And how did he learn it? Another mentor taught him. And how did he learn it? Another mentor taught him. And how did the first person learn it? Well, he just made it up. So that's the whole thing. Once it's out there that, hey, 50 milligram iodine Lugol solution is the key, it's like, whoa, you got to be careful. So iodine basically can cause thyroid toxicosis. And I've seen a lot of cases being, in my previous practice when I did conventional endocrine, a lot of thyroid cases. And I would see a lot of people doing alternative medicine. and they would have hyperthyroidism. They would be in thyroid storm. I mean, I've seen a kid, it was autoimmune thyroid disease, it was Graves' disease, but he was 25. In less than a week, he died. I mean, the thing is that it was like cocaine on, overdose. His heart gave out. It's overactive thyroid can kill you, so that's the thing. I've seen a lot of severe cases of hyperthyroidism. So I just saw a case about this month, and she's a little crazy, came in, but she had rip-roaring overactive thyroid, and it's like, look, there's no natural supplement that you can do to lower this. I'm going to have to treat you conventionally. And she's already feeling better. So what happens if you have too much kelp in your diet? Well, that can actually slow down your thyroid. So I have people who take a lot of kelp, you check their blood work, and their thyroid goes off. I have many patients with negative thyroid peroxidase antibody. I've checked, I added a low dose, maybe 10 milligrams of iodine, recheck their thyroid test 2 to 3 months later, their TSH is tripled, they're much higher. It doesn't work, they're tired. And they're looking at you like, I thought you were an expert. Like, well, it works for a lot of people, but it doesn't work for you. So iodine excess may increase autoimmune thyroid disease. So you gotta be careful. So just, you gotta respect iodine. Iodine it can basically cause some immune effect on your immune system with Th1 versus Th2. So just remember this, if you had to remember one part of this talk, one thing is that remember that thyroid hormone requires iodination of the tyrosine molecule of thyroglobulin. And attaching the iodine molecule requires thyroid peroxidase. And if you have a positive thyroid peroxidase antibody that's destroying that enzyme, and you add extra iodine, like 50 milligrams, which is humongous, you're going to activate the thyroid peroxidase to attach that extra iodine to to make more thyroid hormone, and then the thyroid peroxidase antibody sees more of this thyroid peroxidase being activated and will start destroying that whole thyroid, and your thyroid will completely fail. So do not use iodine with patients with thyroid peroxidase antibody. So what labs do I check? I check all these. TSH, free T3, free T4, reverse T3, thyroid peroxidase antibody, thyroglobulin antibody. If they have overactive thyroid, which is rare, then I would add a thyroid stimulating antibody. I also check a ferritin level, because the first step of thyroid hormone production requires iron. So you really want a ferritin level over 50. Some people say 70. I check a full iron panel with it too that comes with the ferritin. I look for adrenal fatigue. Remember we talked about cortisol inhibiting T4 to T3 production. B12, I really rarely order B12 because I just give it to them because if they're tired, fatigued, I just order B12. Some people may have a level of 1,000 and still feel tired, but when they take more B12, they feel better. So as long as they have normal kidneys, they're able to pee it out. You could do a gluten sensitivity test to see if they have issues with gluten. And then thyroid ultrasound, I recommend doing a simple thyroid ultrasound because you can pick up thyroid cancer. And then you check the thyroid antibodies there too. So if the thyroid nodule is over like a centimeter, recommend send them to get it biopsied with ultrasound guidance. And I've been doing that for 20 years. And about 10% of thyroid nodules are cancerous, but they have the best prognosis if you catch it early. Yes?
Which lab do you use for the gluten sensitivity test?
All right, the gluten sensitivity. I have a new nurse practitioner. Her name is Becky. She is a gluten expert. She loves to use the company by Cyrex, tomato, Cyrex, and it's probably array number 2 that looks at like 50 different parts of the gluten part, from gliadin to some, so that's very detailed. I think that's probably the best test. Do I order that? She orders it left and right. To me, I just say try to be gluten-free. But she's on this mission. She wants to tell her patients, it's your gluten. So anyway, selenium helps, especially with patients with positive thyroid peroxidase antibody. Be careful with iodine. We talked about that. And then zinc helps, and iron if their levels are low. So T4 is the standard thyroid, and most people are going to be on T4. It's cheap, it's inexpensive, but I really think that they need a combo. They need probably a mix of T4 with T3. You can use pure T3 if they have mild, really TSH of 3 and they're just symptomatic. Maybe start with some T3 and see how they do. There is some people that basically just use T3 and they titrate huge doses, but I think most patients benefit with a little T4 mixed with the T3. I don't think we understand the entire thyroid pathway, and I think even though T4 is considered a pro-hormone, I think that, in my experience in 20 years of doing this, there are people that say, you know what, I need that T4 because I've taken them off T4 and given T3 and they go, I just don't feel right. So I think it's a mixture. You just have to find the right combo. And then the T4, T3, you can get it compounded, have sustained release. You can use 50-50 or 4-to-1 or 1-to-4 or whatever combination. You can actually have their fillers as acidophilus, so it absorbs better rather than cellulose. I use a lot of desiccated thyroid, even with patients with positive thyroid peroxidase antibody with Hashimoto's. There's a controversy, can you use patients with desiccated thyroid pills, like Armour, WP Thyroid, West Thyroid, Nature Thyroid, with patients with Hashimoto's? And most of my patients, their thyroid antibodies are generally, over time, I try to get them down. I can't get down everyone, but even patients with positive thyroid, with Hashimoto's, I do not see their thyroid get worse with their antibodies go higher on desiccated thyroid hormone. I've been looking at that for a long time. There's no literature that actually shows that, but I'm just telling you, this is what I've been looking at for some time. So you can use Cytomel. You can add Cytomel with T4. You can use it once a day, BID, TID. So there's many different combos. So you want to kind of lower that reverse T3, and the number I kind of go is under 10. If you're looking at a free T3, reverse T3 ratio over 20. If you do make an adjustment in thyroid medicine, I usually recheck in 6 weeks to 2 months. Try not to suppress the TSH, respect it, because there's that hormone TRH. And then if you do suppress it, you're going to get in a lawsuit if you don't basically check urinary peptide. It's like rheumatologists ordering steroids, not checking from bone density, and then they all have osteoporosis. If you're over-replaced and you're not checking for bone loss with either bone densimetry or checking a urinary N-telopeptide, and they fracture, you may get in trouble. So just protect yourself. Screen, especially over 50 years old, with thyroid ultrasounds to see for thyroid nodules. I mean, everyone has some nodules. Just if it's over 1 centimeter, recommended to get a fine needle aspiration under ultrasound guidance. And you can pick up a lot of thyroid cancers. So anyway, I'll have Jamie come up and he'll talk, I don't know, a little about thyroid. And so this was a little trip that I did with my friend and I, who's actually an attorney. It's kind of funny. But we did some rappelling in Colorado. All right, so Jamie.
Thanks, Dr. Lita. It was very helpful. There's been a lot of confusion or misunderstandings or controversy about this whole iodine issue. So we have a couple options for you. For these people that do not have the thyroid peroxidase antibodies, then you can use the iodine even at the higher level. And the nice thing with our formulation is the iodine plus in a capsule, he had mentioned a key nutrient is tyrosine, right? So we have that in the formulation with the iodine. And then he had also mentioned a good way to reduce these antibodies was with selenium. We also feel that the selenium does a really nice job of detoxifying the thyroid. So for those people that it's okay, you can use the iodine plus capsules that has the iodine, iodide, selenium, and tyrosine. If you want a lower dosage, we have another option for you. That's the iodine plus in a liquid that has 75 micrograms, so a lot less, and also has selenium, excellent for kids and for people that are more sensitive or have some of these antibodies. So if you want to help them, you can, and a much more conservative route would be the iodine plus in a liquid. In addition, we are excited that we are working on a new formula that would use some of the glandules we were talking about. We've been using it in 2 facilities right now, and we've gotten excellent feedback from a couple of docs that are using this. So that should be out sometime later this summer. And we have the endocrine tincture, which has been excellent. It's a liquid organic herbal tincture. Again, really helps with the energy, and it's a nice formula because it's a liquid and you can modify the dosing. So the formulas we have now are the iodine plus liquid, low dose, which has the selenium in it. The iodine plus in a capsule, higher dose, but it has the selenium and the tyrosine. Then we have the endocrine tincture, which is a liquid organic herbal tincture that you can use not only for thyroid, but also for hormonal balancing, okay? So we're gonna pass out some literature, all right? And we also have, Dr. Lee is a top-selling author, and I think he has 3 books now? 4? So we're going to give you a free book today on, it's an excellent book for kids and heart health. So it might be something that you want to have for your family or put it in the office. And these are also available for you to sell through your office if you want to carry some of his books. A lot of our clients have picked up books and videos and things like that. So excellent book. We're going to give you guys a copy now. We're going to take a quick break, and then we're going to finish the last hour, and we're going to be focusing on insulin resistance. So let's take about a 10-minute break, and then we'll bring it home, okay? Thanks, folks.